Welcome to our discussion on antibiotics. We're going to first start off with some basic definitions. So, a definition of an antibiotic, remember this is not an antifungal, this is not an antihelminth, this is an antibiotic, right, against bacteria. So the medication itself, the definition of an antibiotic medicine, is to treat bacterial infections. And ideally you want to have a culture so that you know the exact organism in that infected area. This could be your sputum, this could be a wound. That's why we do the cultures, is so that we can identify the exact organism and then target it with a medication specific to that organism. Now, we talked about this briefly in lecture, but empiric therapy is when you're treating the infection before you have those culture results and you're doing your best guess on what kind of organism is in that region. A lot of times we do it based upon the suspected infection. If it's a UTI, you could pretty much assume it's E. coli, right? Same with wound. A lot of the times we suspect staph, those kinds of variations because of the location and the nature of the infection itself. Prophylactic therapy you will see when you're trying to treat or to prevent an infection. And so you'll see that, after you get stitches, you'll have prophylactic antibiotics, depending on the nature of the wound. So if I slice myself on a steak knife that is covered in steak juice, right, they'll clean it out, they'll numb it, and sew it up, and then they most likely will give me prophylactic antibiotics. This is not because I have an infection, but to prevent me from getting an infection. Therapeutic response. This is the response that you want to see, the signs that it is working, right? Subtherapeutic, meaning less than therapeutic. It means that, it's those same signs of infection, inflammation, pain, fever, white count, all those, that it is indicating that the antibiotics are not working. And then when you're looking at your antibiotics, make sure that you understand the actions of the antibiotics. How do they work? So I'm going to bring in some new terms for you, bactericidal. So bactericidal means that it actually kills the bacteria. A lot of times it'll puncture the bacterial wall itself and lead to the lysis of that organism. Bacteriostatic, on the other hand, inhibits the growth of the bacteria, the ability for that bacteria to proliferate. So they don't kill them instantly like a bactericidal, but instead they make it so that they cannot grow and continue to contaminate, and your body does the rest of the work. They clean up the business, right? So, combinations of antibiotics. Typically, we try to avoid combination antibiotics, but there are cases where we do use 2 or more antibiotics. In sepsis, you'll see 2 antibiotics, right? So severe infections that where it's prudent to have 2 different kinds of antibiotics at the same time. Additionally, if you have an infection with more than one organism, so you grow it on your little agar plate and you see that it's got some gram-positive and some gram-negative rods, right? You're gonna consider doing 2 different antibiotics to treat the 2 different organisms in that wound. The treatment of tuberculosis, we touched on this in lecture as well, that TB is really resistant because it forms those little endospores. And so we tend to do multiple kinds of antibiotics for a long amount of time to help with tuberculosis. And then treatment of infection, in which combined therapy usually enhances the effect, right? So you'll see colitis or diverticulitis where we'll send you home with 2 antibiotics because they work better together. Now, diving deeper into my prophylactic, right? So some surgeries, they will provide prophylactic antibiotics prior to, right? Especially like electives or plastic surgery. Sometimes they'll provide you those antibiotics in advance so that you can have antibiotics on board before the first incision. If you're neutropenic, if your white count is really low, they may provide antibiotics in advance because you are at such an increased risk of infection. Recurrent UTIs. It's not uncommon to see that the doc will have a prescription, or the provider, excuse me, will have a prescription for antibiotics for when you start to feel those symptoms of UTI. And so you will take the antibiotics even though you do not actually have confirmation that you have a UTI, and you may actually not. The other one is when you're getting dental procedures. If you have a prosthetic valve or a prolapsed valve, anything that could actually lead to growth on those heart valves themselves, they will tend to give you antibiotics before dental procedures. So you'll see prophylactic antibiotics with people that have risks for endocarditis. Now, when you're looking at antibiotics in general, the goal is to never use them if you don't have to. And we're doing a better job in America, but we don't do a great job of it because it is not uncommon to go to the doc, have like an upper respiratory, you've got runny nose, you're stuffy, congested, and they give you a Z-Pak prescription. Now, the majority of the time, more than 90%, those are viral infections. So it's inappropriate to prescribe an antibiotic for a viral infection. And in fact, it's dangerous because it leads to resistant bacterial strains. So attempting to treat untreatable infections, right? So if you have some, you haven't identified what the problem is, or you have like a MRSA that you have not cultured out yet, that would be untreatable. It is resistant to the main penicillins that I would give for a staph infection. So growing them out and seeing that culture and sensitivity so that you know which antibiotics to provide is the prudent thing to do. Fever of unknown origin, this is a similar thing. You haven't found the pathogen, you haven't found the infection, right? Because if you're just giving antibiotics, you want to try to target the pathogen that is making the problem. So if you have a fever of unknown origin, it means you haven't found out why their body is behaving that way. You don't know, is this an infection of the skin? Is this the GI tract? Is this blood? Is it endocarditis? Is it pneumonia, right? Is it UTI? Where is the infection coming from? And the reason for that is I would use a different antibiotic, a different treatment, depending on what that pathogen most likely is. Now we're going to step into the actual different types of antibiotics. Now, pay close attention as you're going through this lecture and through these slides, because exam 1 has a lot of antibiotics, a lot of medications on it. And so make sure that you understand the antibiotics. How do they work, right? What are the indications? Where do you normally see them? And any common side effects. So, take notes to yourself, and as you're reading through the chapter, just make sure that you're a little hyper aware on the medications themselves. So we're going to start off with my sulfonamides. Sulfonamides, yes. I'm like second guessing my pronunciation. And these are the first line treatment. These are your sulfas when people say, oh, I'm allergic to sulfa, right? These are your first line treatments for UTI. This is first class of antibiotics, right? There's a couple different kinds. And anytime you see that sulfa prefix, it is a sulfonamide, right? The mechanism of action, it is bacteriostatic, meaning that it doesn't kill the bacteria itself, that it actually prevents the bacteria from proliferating, from making a big group of bacteria, right? It prevents the synthesis of folic acid that is required for the synthesis of purines and nucleic acids in bacterial synthesis, right? So it prevents the bacteria from being able to divide and make more of themselves. Like I was saying before, most commonly you'll see this in UTIs because it's really good against E. coli. E. coli is very, very common as the main culprit for UTI. But you'll also see sulfas for other infections, Staph aureus, right? Proteus vulgaris, this is not as common. E. coli is very common, and you'll also see sulfas added, and so you'll see a combined 2 different antibiotics in one med. Oh, see, here I go. So where you have your oral therapies for urinary tract, where it's the second choice nitrofurantoin. This is the main one that you'll see too for UTIs, or you'll have it as a mixture in the same PO med. There are other uses of sulfas, right? So upper respiratory infection like pneumocystis jirovecii pneumonia, and then in combination, like I was talking about. Anytime you see that sulfa prefix, that is your sulfonamides. And so they are more effective in a combined use. Like Bactrim is very, very common for UTIs. That's one of the most common ones we'll see, Bactrim and Macrobid. You can also see them combined as well with erythromycin, which is mycins are for molds, right? So erythromycin with the sulfa for that middle ear infection. And those are the most common ones because it is more effective against the bacteria in your ears and urinary tract, because it's typically those the E. coli, like I was saying. Some of the adverse effects that you can see with sulfa, besides allergic reaction, right? Because a lot of people think or have had some kind of allergic response, and so they just all sulfa's off the table. And so you dig deeper into what was that, and if they say, oh, you know what, I had, nausea and diarrhea. This is not necessarily like an allergic kind of reaction, right? Because our gut is made up of a lot of bacteria, so it's impacted when we take antibiotics. And so digging deeper into what the reaction was that the patients had. The big ones that you'd worry about, like any blood dyscrasias, like hemolytic or aplastic anemia, thrombocytopenia, your platelets are low, right? Those are very concerning. Integumentary, great photosensitivity on my sulfas. And Stevens-Johnson syndrome, this is SJS, also called red man syndrome. And literally their skin kind of overreacts. They become really red and blistered, and the skin kind of blisters up and then eventually sheds off. And SJS is, they're in the ICU with that, so it can be very, very dangerous. GI-wise, we talked about nausea, vomiting, diarrhea. Pancreatitis, you can have convulsions with as an adverse effect for sulfas, but making sure that they take it with food because of that nausea vomiting part, and then a lot of water if they can. Like my CHF people obviously do not want to be taking 2 liters of water, but making sure that you take it with food to avoid that GI upset. And now we're going to move into our penicillins. Now, penicillins were first discovered in the 1940s, and this was actually kind of the introduction of understanding that we can kill off microbes with other microbes, right? So they stumbled across it accidentally, where they had mold growing at the same place where they were kind of looking at other microbes, and they saw that it inhibited growth in the same place where you like kind of a perimeter ring around these molds. So they end up kind of researching more and then isolating it out, and then started using penicillins clinically for bacterial infection. And it turns out that they are bactericidal, and they work by interrupting the cell wall itself. Now, penicillins kill a wide variety of gram-positive and some gram-negative. Mostly the gram-positive because it interrupts that cell wall. Gram-negative, remember, has another outer wall that makes it more resistant to penicillins. Penicillins are also called beta-lactams, right? Because they work on that beta-lactam to disrupt with beta-lactam to disrupt the cell wall synthesis. Bacteria, there are some that produce enzymes that are capable of destroying penicillins, known as beta-lactamases, where they inactivate the penicillin molecules itself, and as a result, the penicillin is not effective at killing that bacteria. When you're looking at the initial penicillins, my natural penicillins are narrow spectrum. They're not a broad spectrum antibiotic. And so penicillin G, V, right? These are examples of my natural penicillins. And then we get a little more broad spectrum as we come down. The aminopenicillins are more broad spectrum. And then the extended spectrum, piperacillin. These guys will actually see them frequently in the hospital. Like piperacillin, you see it all the time. Amoxicillin, you'll see it at home too for like my ear infections and those kind of upper respiratory infections. when you're looking at penicillin enzyme, right? The chemicals that are developed to inhibit these enzymes, clavulanic acid, tazobactam, and sulfobactam. It is to inhibit the enzymes that the bacteria makes that prevents them from being affected by the penicillin, to break up those cell walls. So the